I guess that's my cue. Great. Well, again, thanks so much for giving the opportunity to present. This is kind of a topic that's been on my mind for a while, and certainly on my heart for a little bit. I'm glad to get to present it. Certainly, if there are questions afterwards or thoughts that people want to email, this is still a work in process, a progress. And if and there's room for refinement and comment and commentary because I think um, that would be helpful. A little bit of background on me. I grew up, or my family's from the Midwest. I was born in Ohio. Actually, it was a family physician, I guess, who delivered me. That's not a direct memory, but that's what my parents have said. I grew up mostly in Florida, went to medical school there, went to residency in Oklahoma, ended up in South Carolina working in a small town called Prosperity for a number of years that does full spectrum obstetrics. That was something that I wanted to be a part of. Went overseas for a while, did some disaster relief, ended up back here after that period of time, and had I liked working in rural medicine. I had the opportunity to go back there, but they also had a teaching position here at the university, and obviously that's where I decided to come. And I tell people that they needed someone who would deliver babies, and they were willing to tolerate someone who wanted to do some global health work. And most of the time, I feel like I made the right choice. I did just, and this is somewhat degree preaching to the choir, but I did want to at least mention a brief global perspective on maternity care because it does make a difference in how I think about things. If you want to click that, there's a couple of words underneath that, and one of the main things is that maternity care really is effective. I mean that I mean just in terms of things that have made a huge impact on the health of the world. There's reasons why maternal child health makes it on every one of those World Health Organization quality metrics because this is something that we make a really big impact on. If you go to the next slide, this is older data, but it gives you kind of an idea. This is maternal mortality per 100,000 births. That's per pregnancy, and you can see that in some countries, particularly if there's not really good access to care, it's almost 2%. It is 2%. That's two out of every 100. That's 1 out of 50 pregnancies ends in the death of the mom. So you have more than one kiddo. You can get to you get to places where you know 1 in 10 women die of some pregnancy-related, complication. In contrast to other places like, gosh, in this one, Sweden and Australia, it's down to 4 per 100,000. And that's like a 500, times reduction. That's more, 99.5, I guess, percent reduction in something it's not like it's a rare disease. I mean, just about half the population is really likely to experience pregnancy, and about 100% of the population pretty much owes their life to a successful pregnancy. So this is one of the areas where things really make a huge difference. We talk a lot about access to quality and trying to be able to provide quality obstetrical care, quality maternity care. That's something that we really need to be doing, but a lot of it is access to that care really matters a lot too. Just to point out, it's not like it's unique to around the world. United States and Europe is the same way. If you look at our maternal mortality was running around, 800 per 100,000, kind of like a lot of the other countries around the globe. But over about a 20-year span, kind of from 1930 to 1950, really had dramatic reductions in maternal mortality. And that was just because we really started developing good treatments for a lot of obstetrical conditions. Obviously, room to go, obviously, still ways to improve things, but a lot of what we do really works if we can get people access to it. What I wanted to talk about was that some really more on the access side, more so than the quality side. And my feeling that um, family physicians working in rural areas are perhaps an underutilized resource in prenatal care. So we'll talk about how the access is pretty variable. Again, this is to some degree probably preaching to the choir. Some of the barriers that reasons why that access to maternity care is difficult. Why I think prenatalist family physicians, that would be, we'll talk a little bit about that and what some of the barriers for that might be. So this is an older map. This is from 2012. And it's looking at obstetrical practices by county. And as you would expect, there's a lot of range. You go from places that are essentially blank, right, where there are counties where there is no obstetrician. So that's an access problem. Number of counties where there's maybe one or two or three, and then some with a handful, and then others where it's almost too numerous to count. And so this is 2013, so we would like to make an impact. This is a more recent one I had some folks make last year. Different group of folks used some different colors, but the shading's pretty similar, right? I mean, there's still a lot of blank counties, some with a little bit of shading, and then some that are pretty dark. And that's over a 10-year span. Our desire is, gosh, I really wish we had more obstetricians in rural areas. Wish we could make that happen, but haven't made a whole lot of impact on that. And I want to talk about at least, I mean, some reasons for that. So this is looking at just births per county, and you can see that while there's a large number of women who, in aggregate, are born in rural areas, they are spread out and they're sort of diffuse, right? And so if you're in Allendale County, they only had 63 deliveries in the county. Bamberg had 134, whereas places like Charleston and Spartanburg have thousands. And that's an issue. That's one of the barriers for obstetrical care in the county. If you want to go on to the next slide, and then click on through, that's it's well and good to say, gosh, I wish we had more obstetricians, but if there's only 63 babies in the county, you could deliver every single one of those kids and still not be able to keep your doors open financially. It's just a very practical issue. Most obstetrical practices my OB friends tell them they'd like at least 100, usually 120, to really kind of be there per year. And if you're doing that as a solo practitioner, that's being on call all the time. That's not easy. Now, if you've got obstetricians that'll do that, my goodness, they're fantastic and they should keep doing what they're doing. But it is difficult to recruit people to do that. And you can see from those maps over a 10-year span, it's hard to find folks that can. Um, so if you want to go on to the next one, some other also, the other issues, of course, not only is the volume issue one for our obstetrician physicians, but the hospitals got the same kind of things. A lot of those counties don't have a delivering hospital, and it's going to be really hard for an OB to set up shop if the hospital is not a delivering facility. Midwives, I like midwives. I think midwives are fantastic as well. But some of those same barriers to rural care are going to exist, and that they're also going to need a place to deliver. They're going to need a certain volume to be financially sustainable, and they're going to need a relationship with the delivering physician. So we'll talk a little bit about family physicians, somehow what that looks like. So this is the same kind of map looking at family docs. And one of the big advantages that family medicine brings is there's a lot of us, right? There are no blank counties for family medicine. Whereas we had a number of them for OB. I mean, there's some with not very many family doctors, but there are no counties with zero. So that's something. There's a lot more dark counties, dark red ones with lots of folks, some with fewer, and certainly some folks that are overworked and stressed in those areas. But it's a lot more of a broader practice. So when people think about family medicine with obstetrics, a lot of times folks think about folks like the Office in Prosperity, where the doctors are providing comprehensive OB care, and I think that's another great resources when you have folks who are able to do that. One of the big advantages is that at least from a financial perspective, the family medicine with obstetrics can handle a lower volume and still be viable, right? I mean, if there's only 80 deliveries in the county, but maybe you've got, a three-doctor practice, they can be viable. They will. That's an additive thing to a busy practice rather than something that's really going to be hard to sustain. Obviously, still requires a delivering hospital. At lower volumes, malpractice can be an issue. There's at least some thoughts. You have to make sure that there's a certain volume to maintain technical competency. But then there's also one issue, and this it hurts my heart to say it, but I feel like I got to be honest, is that the number of graduates from residency programs in family medicine that really want to do labor is small. It's not zero. There are some that want to do that, but it's not a huge number. And so at least I just feel like that has to be recognized. So one thought is that, well, maybe you could be a prenatalist, and this is a word that's sort of in contrast to a laborist, right? A laborist would be a doctor who does maybe labor at a hospital, labor and delivery. Maybe they do the deliveries, but not the prenatal care. This would be the reverse of a physician doing the prenatal care, but not the labor. And this is something that I think might be something worth looking at because and this would you could set up a nice little partnership in a number of ways, and people do this. This is not a totally unheard of thing. It's a little unusual in South Carolina, but it's done in other places where you maybe have some sort of partnership between the prenatal physician and the delivering physicians, and maybe and you could set that the exact terms of that partnership up in a way that was suitable. When I was in Oklahoma, we had one where there was a nurse practitioner. She did all the prenatal care up until 36 weeks, then transferred them to us, and then we took them from there. But I could see it being done in a variety of ways. Maybe the delivering doc wants to see the patient at least once early on to see if this is a low risk pregnancy that they would be comfortable getting prenatal care out in the community, and then maybe see them again at 36 weeks. Um, Maybe they want to see them trimesterally. You could do it a variety of different ways based on sort of the comfort level of the different sides of the partnership. This does have some advantages, right? I mean, well, I mentioned that I find it's a smaller number of family physician residency graduates wanting to do labor and delivery. A lot of them like the prenatal care. A lot of times, folks like young families. If they really one of the draws for people going into family medicine is that diversity of ages, and being able to have young families is a really nice advantage. This adds some diversity to the practice in that way. And if it is a less busy practice, then the prenatal visits do provide some revenue. So there can be some advantages there. For the delivering docs, for the delivering community, well, you know, not that it's all about money, but it is a straightforward source of revenue, right? If the laboring physicians have confidence in the physicians providing the prenatal care, well, they get to do the ultrasounds and they get to do delivery with somebody else doing all the prenatal care. And that's not a bad deal from a fiscal perspective. Also, it kind of strengthens some of their other gynecologic referral patterns because you get to know those doctors on both sides of the partnership. And the patients, I think, would find it useful, right? I mean, a lot of the patients, they would be going to the doctor that they might already be going to. That this would be the patient's primary physician, and then the family doc might be taking over. And if not, at least they're already established in the community and very conveniently located. We know that travel and transportation is frequently a barrier to some of our lower income folks in rural areas. And then, the patients, if they don't know where to take their child, most of the family docs would be happy to take care of the kiddo too. And that sort of continuity of care can be helpful in a variety of things. Also, we were talking yesterday about screening for postpartum depression. That's a very nice kind of family-centered way to be involved in some of that broader care. So I think it has some advantages in a lot of ways. If you wonder, well, has anyone endorsed this? And well, not exactly. This is sort of, I don't know, I sort of feel like I'm cheating, but this is, the ACOG they do officially endorse the hospitalist or the laborist model. And my sort of feeling is that, well, if you are endorsing a laborist model, you are at least implicitly endorsing the idea that there may be physicians doing prenatal care that are not doing the labor. Um, so that's a little bit of a stretch, but maybe. Some barriers, right? Philosophical, you might be worried that this is more fragmented care because one person's doing the prenatal care and somebody else is doing the delivery. But I don't know that that's much more fragmented than what a lot of our folks experience already. Um, there are some real practical barriers, and the really big three that I see is one is splitting the revenue. For global payers, trying that is a barrier to try to figure out how to divide up the prenatal expenses from the laboring perspective and make sure that you're not violating any contracts. But for Medicaid, that's not an issue because Medicaid, those are already divided. And in rural areas, that's the lion's share of our prenatal care and our pregnancies under that model. And so that is not a barrier for that for folks under Medicaid. Malpractice coverage is another one that needs to at least be addressed. Malpractice, I mean, prenatal care. while it does cover, they do get paid for the visits, it's not a lot. And so there's not a, you can afford maybe a slight increase in malpractice coverage if you're doing prenatal care, but not a bunch. I mean, you can only accept a little bit because the revenue is not that great to cover the amount. When we talked about this about 10 years ago, though, interestingly enough, the JUA at that time was willing to bend on this, and that at least in some certain rural areas, they were willing to pilot a program where they would include prenatal care at the same rate as general family medicine malpractice, which was huge. But then the third piece, and this is probably in some ways one of the more, I guess, difficult ones to do, is to build the relationships between the delivering and the prenatal physicians in a way that that can work and can be viable and still kind of and be enjoyable for everybody. So yeah, as we mentioned, splitting the revenues fairly easy. The global payers is harder. We can go on. The malpractice, as I mentioned, and also I should point out that for federal programs, my understanding is it's generally not an issue. And when I have seen people use this model, it's very often been FQHCs or military programs where the malpractice is sort of lumped in together. I'm actually kind of curious to know that for what I just I haven't explored if with some of these larger systems that self-insure that would seem like if they might be willing to consider entertaining that because it would help preserve some of the system continuity. We can move on. So yeah, so some of those runs we had one of Renzi. I mentioned there was a nurse practitioner at the health department who would do all the prenatal care and send them in. Some of my colleagues who have worked at FQHCs in California have used this model. Um, And we honestly, we have some similar things, and we maybe I think Dr. Whittle will talk about it. That's not exactly what we're talking about, but somewhat similar in that a partnership where one of our clinics in Winsboro has been doing prenatal care for years, and we've had a very good relationship with our OB department and for some of our higher risk folks to be able to collaborate with them for some of the when things become a little bit more difficult. One big thing to mention is that when people start talking about this shared model, that people want to start talking about telemedicine. And I think that telemedicine can be an avenue for some collaborative visits, but I don't think telemedicine works for all the visits. If you try to say, well, oh, we'll just have the patients go to the family doc and then do the televisits there, that's just not going to be practical, right? The offsite consulting physician, who's usually the MFM or maybe the OB, they get the physician, payment from Medicaid, which is fine. But then the facility charge, which would be the rural doc, they only get 15 bucks. And, you could eat that, maybe for a selected couple of visits. But as a routine thing, that's, to cover the cost of making the appointment, rooming them, getting the vitals, checking the fundal height, doing the fundal, fetal heart tones, doing the urine, and just handling all the technical issues and phone calls for 15 bucks a visit, it's just not going to happen. So, unless there's a significant revamping of the financing, I don't see that telemedicine would work as the primary driver in that way. Um, Another additional consideration that's really come up more than when we were kind of exploring this a number of years ago is that, rather than family physicians being more independent, most family physicians, even in the rural areas, are very frequently employed within the larger systems, and the systems would need to kind of sign off on this and, in order to kind of move forward on this. So anyway, that's at least the kind of the things I wanted to introduce. I don't think prenatalists, this is not a new thing. People do this around the country. And to some degree, we already do it a little bit in South Carolina. But I think it has some real advantages as one tool. Again, not the only tool, but one that might work well in rural areas. I think a lot of the practical barriers are potentially surmountable. Um, and so it seems like kind of a low-hanging fruit and something new that we could try because it's been so difficult to move the needle in getting good access to rural areas. So, I guess some other just barriers to think about how the bigger healthcare companies would react. The folks like the Prismas or the MUSCs um, or the McLeods. And then also in order to build the partnerships, we would need interest on multiple in a couple of sites. Wouldn't need a whole lot of sites. I think being able to have just a few sites where you could really kind of pilot this and see how it works might be a good one to evaluate and monitor outcomes. And if it's effective, then we could kind of promote it on a wider basis. I think I've done questions before, and Rachel may be able to help. Maybe this, if this is a